Dr. Mehdi, please.
I cannot activate. It's not activated. I don't know how to activate.
Now repeat
Should
again.
be activated by the okay.
No, you can.
No.
Good.
Yes, we
It's
can
okay
see.
now.
Yes.
You can
Is
click the full
activated?
presentation. Yeah,
Okay.
yeah, okay. Okay, yes, we can see
I
it.
can start.
Yes,
Dear
sure.
moderator, dear colleague, I will talk about complication avoidance in the management of cervical OPLL. OPLL is an inflammatory process resulting in the replacement of the PLL with lamellar bone. This leads to reduce the spinal canal and then to the compression of the spinal cord, which can contribute to degenerative cervical myelopathy. The prevalence of PLL is higher in Asian and range from 0.1 to 1.7 in American and European, and very, very rare in our country in North Africa. The diagnosis is made by radiological assessment, especially with CT scan, plain radiograph, and MRI. Only symptomatic patient, moderate and severe
We cannot hear you.
I'm afraid his connection was lost. He has trouble.
Okay. We can wait for a while and then maybe we can connect again.
Maybe we can take a question and I will call the Professor Mehdi by phone.
Okay, it could be. Now we have a time to wait the Dr. Mehdi and then we can have a questions from the participants.
Mm-hmm.
Okay.
We'll
Anyone
continue with the question.
Yes. Anyone has a question?
I have a questions from the chat. I can read them. So the first question was about repairing dura. If you have dura trauma during the anterior approach, how you can do this. So this is to all the talkers. So this is from the chat. All the lecturers can answer it. Oscar, if you have a dural damage, what are you going to do?
The first thing to know is a dural tear in anterior cervical spine is not as bad as a dural tear in lumbar spine, okay? The flow of CSF is much smaller. So normally what I do is just use some sort of patch and glue, and most of the time will go away. Of course, if it is a high flow fistula, you would supplement with a lumbar drainage for some days and watch how it goes. But generally, it's not as complicated, as difficult to manage as and anterior repair. It's not easy, especially in the setting of OPLL. It's quite complicated. But that's my general approach.
Okay. So we have another question from the chat. What the rate of recurrent of OPLL? Rate of recurrent.
You know, I think with anterior techniques, the ones that tackle the OPLL, anterior floating or Zen technique, the recurrence rate is really, really small. Whereas if you go posterior, if you do a laminectomy alone, that's the worst scenario. It can be almost 2/3 of the patient. If you do a laminoplasty, almost half of the patients, the OPLL will grow. And if you do a fusion, that's the best scenario, around 30% of regrowth of the OPLL. That's a general, these are general numbers.
Yes. And
I think Nobuyuki can answer that question better. And he paid attention that it is a progressive disease. If you leave the
Yes.
OPLL, it progresses. We know it well. What is the recurrence rate, Nobuyuki? What do you think?
Thank you. And the progression of the OPLL is a much important issue for the patient and the surgeons. Just posterior decompression is indirect decompression. That's why I should take the multi selection and technique we surgery should have, and depend on the cases and the level of the OPLL, we should select the selection of the approach.
Okay. We have one more question from the chat. The question is about Artur Goel technique, that he recommends only fusion during the OPLL. What is your, and he thinks that the compression is not necessary. What do you think about it?
I think the best guy to answer this question is Mehmet. I heard Mehmet giving a wonderful lecture on the topic in front of Atul in India. So Mehmet, please.
This is a good. Actually, Atul was with us. Are you here, Atul?
Yes,
Atul
I'm
has
here.
Oh,
connected.
great, great.
Hi, how are you? The question is for you. Actually, one of the participants is asking the value of only fixation. Would you like to say something?
No, as you know, I'm absolutely convinced. I have no doubt. And I am talking now on the basis of a very big experience that there is no need to do a very extensive decompression or any kind of decompression. Only fixation is the treatment, and magic is the clinical result. You see, it has to be just seen and believed. It is not, when we see images, when we see the MRI, we see the huge compression and cord getting compressed, and it is, nobody can believe that such compression you don't have to decompress. But you just do fixation without any kind of decompression from front or from behind. Mehmet, as you know, I have been talking about this for a long time now. I'm sure, I'm convinced that this is the future of the treatment.
Okay. My comment on this issue is I have explained in Atul's meeting in Mumbai. Yes, fixation helps to stop the progression of OPLL. Because of that, I prefer laminectomy plus fusion surgery. Because of that, especially in the younger patients, because the progression of the OPLL is a very long duration process. The second thing, making no decompression and only fixation is not very well validated yet. Actually, although Atul presents very nice results, we need comparative studies, multi-center studies to learn the outcomes of those patients. This is my response.
Thank you. I have the question to all the participants also. What do you think of role of neuromonitoring during this procedure? Somebody use neuromonitoring?
Yeah, actually, I do sometimes, but we also did a very detailed study on the value of monitoring in cervical myelopathy patients, and we found that it's very valuable in cases to prevent C5 nerve palsy.
Yes.
Especially EMG monitoring of the deltoid muscle. But we did not find very significant differences if we monitor MEPs of lower extremities or SEPs of lower and upper extremities. We did not find significant differences in outcomes in monitored patients and non-monitored patients.
Thank you. Any more questions? Somebody want to ask more questions?
So Nikolai, I wanted to ask to the Zen chain, and he has very nice technique, anterior techniques. And I wonder about micro decompressions, and sometimes we make corpectomy under 2 levels if there is a OPLL, but he make a lot of levels with anterior and only micro decompressions. And Professor Zen, do you compare with micro decompression and corpectomy? What is the differences for results?
Excuse me. You mean ACF and ACCF between the difference?
No, I want to know about you make multi-level microdiscectomy with anterior level. In these cases, we select sometimes posterior approach for with laminoplasty or laminectomy, but you made 3-level, 4-level with anterior and for microdiscectomy. And I think it is useful again because you use these techniques. And I wonder about differences when you select posterior and anterior multi-levels, and how's your results for all of the anterior when you compare posterior approach?
Yeah, I understand. And in the beginning, when we begin this technique, we use the technique to treat most of cases of patients, whether the K-line is positive or negative. And I found that most patients can get a much better result than posterior approach because the axial pain is we worry about the posterior approach. And in the anterior approach, it's minimal invasive. And so we furred several levels, but the approach is minimal invasive. The patient recovered very quick after operation. But anterior approach, we will need cost more time and more surgery times. So sometimes after several years later, if the K-line is positive, now I would like to perform posterior approach laminoplasty much better. And if the K-line is negative, then we choose anterior approach ACF to treat the patient.
Thank you.
There is one more question. I see the raising hand also.
Yeah, Jalal Najar. Yeah.
Good evening, and thank you all for your kind presentation and great information. My question is, if half of the cases will be deteriorated by observation, why we did not recommend surgery for asymptomatic patients? The second question, if we do a posterior approach for laminectomy and plus fixation, we should make our screws and fixation before do our laminectomy, as I understand. And thank you all. Is my question clear?
Yes, I think Dr. Zileli can answer this question. Dr. Zileli, Do you think then the
I'm not the speaker. Actually, the question goes to the speakers.
but you
Your
suggest
chairman.
that the laminoplasty and the fusion could be together to prevent the progression of the OPLL?
Yeah.
So
Yeah,
that's why the participants ask this question.
Oscar, what would you say?
I can add, starting from the last question, which is a technical question. What I normally do on laminectomy and fusion, I remove the spinous process, and this gives me the possibility to do medial angulation, lateral angulation of the lateral mass screws, which is the next step. And after the construct is done, I do the laminectomy. So that's the sequence of my surgery. And the first question.
By high-speed drill. By high-speed drill, not by Carrison, of course.
No Carrison. Drill all the time. You thin it as much as you can, and then you just leave a thin shell of bone, and then with a 2 millimeter Carrison, you take it out. And it comes as an unblock lamina. And the first question, sorry, was?
Was it in why we did not recommend prophylactic surgery for the patient with severe stenosis had no symptoms, as half of the cases will be deteriorated by time.
Right. So as I showed on that epidemiological study, the current situation is most of the patients are offered an operation very late. The mean JOA was 11. And for surgery, and the mean JOA of those patients on that cohort was 9, which is too late. So we need to make an effort to operate those patients. But on the other hand, it doesn't mean we should operate everybody. And we know that most of the patients have stable OPLLs. And if they are asymptomatic, it's nice to give them advice so they can look at symptoms themselves, schedule visits, once in a while repeat an imaging. And I don't think you should operate on asymptomatic patients, truly asymptomatic patients, even though we know that there is a little bit higher risk of spinal cord injury in OPLL patients. I think if you educate them, it's quite reasonable to do instead of prophylactic surgeries. That's my understanding and what I found from the literature.
Yes, mild. The patients with mild symptoms or without any symptoms can be just advised not to have a major trauma, but otherwise just follow up. So there is a conservative management, the sentence, but it's not very well understood what is conservative management in those cases. But just follow the patients without any symptoms with severe stenosis. Even there is a T2 hyperintensity, you can make it. But by the time, if a radiculopathy happens, like a arm pain only, then we must recommend surgery.
I agree.
Same. More questions?
Yes, my question about to repair fusion injury. So anyone has a experience about to duroplasty after the compression?
Well, Cedar, there are many myths in spine surgery, like in brain surgery, and I think this is one of them. I could not identify a single case where I had this problem. And, all the complications or the neuro complications that I had in the past, I could identify what was the problem, what was the technical problem, the bad maneuver that I did during the operation. So I'm not sure. This is one of those topics that we know it, that exists from lab, from animal work, but I'm not sure this is as prevalent as it is described in papers, especially in older papers. I think most of those situations are kind of situations where your technique was not 100% reliable. That's my understanding.
Okay, thank you very much. I think that the Dr. Mehdi come back and then we can continue for the Dr. Mehdi, can you hear me?
Phone, but the laptop, the electricity and the internet in my home not working now. Suddenly, I don't know if I can do this by my phone. But without screen.
Okay. So then I think that it's not possible without screen.
It's not possible? Yes.
I don't know, Dr. Zileli, what do you say about that?
Yeah, he can try to
show
share
you.
the screen.
Huh?
If he can, it's fine.
No, I am in my phone. I haven't the presentation.
Sorry.
So
he
can
it's
show
impossible then.
Without a screen, I can't do it.
Sorry.
No.
Okay.
Yes.
Screen, I have suddenly, I don't know. Suddenly, all the electricity in my home dropped. If I can sharing like this, no.
This is better. We don't do it. Thank you.
Okay.
Thank you, Mehdi.
Okay. Thank you.
Nikolai and Serdar, you can comment on the whole topics and then we can finish.
I think it was wonderful presentations. Very interesting for me, for example, the technique for anterior decompression was very interesting. I think I will going to use it in the future. And I want to thank you all the participants, all the lectures. It was really very interesting topics we covered. And I want to my co-moderator to finish, please.
Yes. We together thanks to all authors and all presenters and also all participants. I think that the cervical myelopathy still has some controversies regarding the surgeries in terms of the posterior anterior approaches regarding the clinical results. So that's why still we will discuss the results of the techniques in the future. Thank you.
Thank you all the participants for being with us. Goodbye.
Thank you. Take care.
Bye.
See you soon.